My talk is about patellofemoral tracking and its management algorithm. It is the most important direction of maltracking is lateral direction, and it ranges from mild degrees to frank dislocation and instability. It occurs mainly in adolescent population group, and it represents only 3% of knee injuries, and is almost 70% related to sports activity. I'll talk about the anatomy and risk factors for the recurrence and algorithm for management. It is important to note that the patellar stability depends on the trochlear morphology once the knee is flexed beyond 30 degrees. So it is dependent on the bone configuration of the trochlea beyond this flexion. And if you have a long patellar tendon, in other words, if you have a patella alta, you will have less engagement of the patella early, and this may predispose to dislocation. The most important static stabilizer is the medial patellofemoral ligament, and it extends from between the medial epicondyle and the adductor tubercle to reach the patella, the upper half of the patella, and it has an insertion to the quadriceps tendon. And it represents 50% of the static stabilization from early extension, from zero extension to 30 degrees of flexion. Vastus medialis is the most important dynamic stabilizer, and it acts and counteracts the vastus lateralis mainly by the vastus obliquus component, which has a horizontal direction. And it also acts by shortening the medial patellofemoral ligament in early 20 degrees flexion. We can have three types of patients complaining of maltracking. Patient with acute traumatic dislocation, which may lead to recurrent dislocation later on. And this occurs mainly in athletes, young population, adolescent group, and the chronic lax patients, which occur in women with malalignment, and the patient present to us with recurrent subluxation episodes. And the habitual one, which is painless and usually occurs with each movement of the knee, and the pathology is mainly proximal, related to tight lateral structures. The most common mechanism of injury in the acute traumatic ones is non-contact twisting injury with valgus and external rotation force to the leg. So, and direct blow to the medial aspect of the patella is less common. Having a recurrency after first-time dislocation, according to many authors, it is related to the number of risk factors the patient had. So it increases from 7% to nearly 80% with increasing the risk factors. Llewellyn at the American Journal of Sports Medicine reported at 2013 a 70% recurrency in skeletally immature patients with trochlear dysplasia. So we have to identify the risk factors because the recurrence will depend on their presence. We have a major risk factors which is highly associated with the recurrence, which is the trochlear dysplasia, the patella alta, and increased the TT-TG distance, that means lateralization of the tibial tuberosity and lateral patellar tilt. The other risk factors for recurrency are less important and includes knee valgus and genu recurvatum and generalized hyperlaxity, wide Q angle, and many other things that counts to the recurrency. However, they are less important than the major one. Patellar instability severity score was described by Balkrick 2014, and he includes 6 risk factors, including the age and history of contralateral dislocation and trochlear dysplasia and patellar height and lateralization of the tibial tuberosity and the patellar tilt. And he gives score 1 point for each one except the trochlear dysplasia 2 points. And if the patient scores more than 4 points, it is considered having a 5 times higher rate of recurrency. Farrick 2017, he uses only 4 risk factors, including the skeletal immaturity, patellar height, using Caton Deschamps, and history of contralateral dislocation. And he reported that increasing the risk factors will increase the rate of recurrence. And he reported that having 2 or more risk factors, surgical option will be recommended in these patients. It is important to identify the risk factors in each case to define which patients are going to recur, to have a recurrence. Clinical evaluation including history of the trauma, the chronicity, level of activity, and history of contralateral dislocation, and including general and local. General examination including the malalignment of the patient if it is present, like Genova valgum, rotational malalignment in the prone position should be assessed, the gait of the patient, and having a hyperlaxity by Beighton scale. Local examination include full knee examination for effusion and for tenderness over the medial aspect of the patella, the medial femoral condyle, and patella height can be assessed also clinically in sitting position, and Q angle, patellar mobility. If it is more than 2 quadrants, it's abnormal, and lateral patellar tilt test to identify lateral structures tightening. Local examination includes also a patellar apprehension, patellar tracking. You can see the J sign on the video, and the femoral version is very important. Having excessive anteversion also is an important risk factor. Tibial torsion, when we have the foot side angle more than 20 degrees in prone position. Radiological evaluation, we will do everything, plain X-ray, CT scan, and MRI. In the plain X-ray, ask for lateral view, skyline view, and long weight-bearing films to have to identify any coronal malalignment. Trochlear dysplasia is a major risk factor and is almost 96% present in patients with lateral patellar dislocation according to Dijour. And he describes that having one at least of 3 signs may identify and confirm presence of trochlear dysplasia, which is the crossing sign, the trochlear bump, and double contour sign. In normal trochlea with normal depths, we have 3 lines represents the lateral femoral condyle, the medial femoral condyle, and the floor. So we have no crossing between them. If we have a crossing, then we have a flat trochlea like this. If we have convex trochlea, convex lateral epicondyle, lateral condyle, then we have like a double contour sign due to medial hypoplasia and convexity of the lateral. And Dijour describes 4 types based on that. We have a shallow trochlea with crossing sign. This is mild type A. Type B, we have supratrochlear spur with a flat trochlea. And type C, we have the double contour sign, lateral convexity, and medial hypoplasia. And in type D, we have combination between double contour and supratrochlear spur. This is type D dysplasia. And also trochlear morphology can be assessed using the sulcus angle, the lateral trochlear inclination angle, and medial trochlear inclination angle. And skyline view can show us the sulcus angle and other things like lateral convexity, medial hypoplasia, and patellar tilt. Patellar height can be assessed using a lateral radiograph, using Insel Salvati index and modified one, Blackburn and Peel index, Caton Deschamps index, and it is very important and it is very reliable. Patellar tilt, it is measured in the axial cuts of the CT and the MRI, and false results occur in the plain X-ray due to the degree of knee flexion we have. And it is important risk factor in many patients with recurrent patellar dislocation. And it occurs due to medial laxity, lateral retinacular tightness, patella alta trochlear dysplasia, or combination of these factors. We can assess according to de jour by superimposed CT scan. We can measure the tibial tuberosity to the trochlear groove distance. It's normal less than 15 millimeter, borderline from 15 to 20. More than 20, we have to do something about it because it is a risk factor.
عمر ما
MRI
عملتلوش
will
اكل كل
measure
ده.
almost every risk factor using this MRI. Patellar tilt, lateral sulcus angle, lateral trochlear inclination angle, and the TG distance also can be assessed using the MRI. What are the available options for us to deal with these patients? We have medial patellofemoral reconstruction. We can do tibial tuberosity osteotomy, femoral or tibial osteotomy in case of rotational or coronal malalignment, trochleoplasty, and in some cases lateral retractor release or lengthening.
يا ماما تهدي يا ماما.
Algorithm for management. Patient with acute first-time dislocation. Classically, if there is no osteochondral fracture, we would go for conservative. If we have an osteochondral fracture, we'll go for operative fixation. But that's not as simple as this. As we know that increasing the risk factors increase the rate of the recurrence. So if we have a patient with acute dislocation with 2 or less risk factors, we have to do conservative treatment. If acute dislocation is with 3 or more, operative treatment is recommended in these patients. If we have a patient with acute primary patellar dislocation, take a good history and do physical examination to identify any malalignment in this patient and any other risk factors like hyperlaxity. If there is tense effusion, do aspiration. If no, do plain X-ray only. If we have a tense effusion, we will do aspiration. And if we found hemarthrosis, we will do X-ray and MRI. If no hemarthrosis, we will do only X-rays. Then if we find displaced osteochondral fragment, we will do operative treatment for the fragment fixation and repair of the medial structures. If no displaced osteochondral fragment, we will conserve by immobilization in extension for 3 to 6 weeks, followed by knee rehabilitation. If we found in the plain X-ray displaced osteochondral fragment, we will do MRI and we will do fixation and medial structure repair. And if no displaced osteochondral fragment, we will do immobilization in extension. If we have a case of recurrent lateral patellar dislocation, now there is no rule for conservative. It is always operative. We have to do something for the medial structures, which is usually the medial patellofemoral ligament reconstruction, plus a la carte approach. What does it mean, a la carte approach? It means that we identify the risk factor in this patient and we manage accordingly. In summary, in a patient with recurrent patellar dislocation and skeletally immature, we'll check for the coronal malalignment. If we have a genovalgum more than 10 degrees and potential for growth more than 1 year, we'll do hemiepiphysiodesis. In case of rotational malalignment, we'll do femoral derotational osteotomy. Medial patellofemoral ligament reconstruction, anatomical if the patient is near skeletal maturity, non-anatomical if the patient has potential for growth. Skeletally mature patient, we address the risk factor present in the patient. Lateralized tibial tuberosity will do medialization. Patella alta we will distalize. Trochlear dysplasia, if type A, we will ignore it. Type B and D will do groove deepening. Type C, we will do lateral facet elevation or resection wedge to decrease the lateral convexity. The medial patellofemoral ligament reconstruction is indicated in many patients. Patellar tilt, if it was more than 20 degrees, do lateral release, but not as a sole procedure. It is only done with other procedures as well. If we have rotational malalignment, we will do derotational osteotomy. It is important to know the landmarks for the medial patellofemoral ligament reconstruction, the upper half of the patella and chotal point. Thank you.